Welcome to KIMEcast, where we break through and cut the BS in sports medicine, rehabilitation, and sports performance, and talk about how things really work. Welcome to KIMEcast. Tony Mikla with Russ Dunning. I just had a great conversation today with the patient. It was kind of stimulating on the idea of Medicare. He's just turned 65 recently, so he's kind of moving into forced into Medicare, which is a really interesting regulatory law. I think when you look at private insurance and what's going on, that in itself is an interesting concept. But then he was talking that the situation he came across was he had been with UC Davis as a group, had a primary physician there who since has retired. And then he was looking to get a new primary physician, which the first appointment available for somebody new was going to be 3 months away, 2.5 months away. But he went to the emergency room on Friday with a cardiac issue, with a potential arrhythmia and having kind of not really shortness of breath, but having some stuff in his heart, palpitations and things. And so he was when trying to get a hold of went to the ER stabilized him, said you can be all right, but you need to see your primary doc and probably have some things looked at and take the next steps here and get some tests ordered. So he's like, well, I don't have a primary doctor, retired. So then, he goes down this bandwidth, and this is where he's at. He's left with a 2-month appointment. So he's super frustrated. So then he called Sutter to see if Sutter could take him and maybe just switch primary care through Sutter. And that was a negative because he said Sutter's not, this is not true to my knowledge, but from what he was told was that the Sutter GPs are no longer taking Medicare. So the closest Sutter provider that he could see is in Vallejo, which is over an hour away.
Oh, wow.
It's awesome.
He's stuck. He's like, what do I do?
Yeah, so talk about dysfunctional. Here's the guy with a heart problem. Went to the ER, stabilized, now I need to see a doc. And then, he's being recommended, okay, we got one for you. It's 2.5 months out. Or you could go drive an hour or two with another organization. But he's 60, he's 65, 66. He doesn't want to follow up in Vallejo for the rest of his life, with the GP, right? Mm-hmm. So he's realizing how difficult it is to get a GP and how short they are. So it was just an interesting conversation about that, and we got into talking a lot about the challenges of healthcare. And it's interesting. So here's a guy who has bought into the system, a veteran as well, so uses the VA as well, which he was impressed with of late, but uses the VA. I don't know what his career was, but it was a solid career for many years. Bought into the whole system, Social Security, Medicare. Now he's here, forced to go on to Medicare, and now Medicare's saying we can't even get you a GP to get some of the care that Then he's like, what the hell is going on, right? So then it kind of got a little political, what's the deal? Why is this going on? So I asked him some questions as we got to talking, because he's like, I wonder what the benefits are going to continue to look like, as there's some threats from the Democratic side that, Social Security is going to be cut, Medicare is going to be cut, Medicaid's going to be cut. And I asked him, I said, have you seen any actions that would affect that? And he's like, well, I look at my statement each month and no, I haven't heard anything of actual what they would change or any changes. And I was like, yeah, I don't think that you're going to see the providers change, if anything. Mm-hmm. I said, but what I could talk to you about is the efficiency of healthcare and where the costs are astronomical. Mm-hmm. And you just witnessed one of them. Mm-hmm. That shortage of providers is a problem. Mm-hmm. And what you also have to recognize is why that's the case. One, it's a lot of providers, a lot of people don't necessarily want to be a doctor right now. So it's not so desirable, right? Mm-hmm. The reason why you heard that from Sutter about cutting Medicare, physicians not wanting to take Medicare, he's like, why do physicians not want to take Medicare? I think because it doesn't pay as much, and the red tape that they put you through is extensive. I said, what doctor wants to be in a system where they go through all this schooling, they have all this certification, they're trying to be world-class at what they do and execute at a high level, and they make a recommendation after the meeting with the patient that the patient needs these medications and should take these to get these tests done, and we'll move forward with the care based on the results of these tests. And then the insurance company denies it and says, no, I don't approve of the test. Mm-hmm. Well, what right does the insurance company have to deny you that? Mm-hmm. What knowledge are they coming from to say that, no, you're a doctor and you should not have ordered those tests, so we're going to deny payment for that. It's not justified. Mm-hmm. And then the doc, has to write a retaliatory statement, more of like a letter form. So he's spending more time trying to prove himself, which he's already proven because he's a doctor, licensed and everything else. And now he has to prove himself again a second time, submits for the request, gets denied. And now then now the insurance company recommends that if you want to continue forward, you have to do a peer-to-peer review, which is an absolute disaster. So this is basically a doctor that's probably best in class trying to push the needle and do what they do, combined with the peer that the insurance company provides is probably not an excellent doctor. Why would you be an amazing doctor and go work for an insurance company and challenge other doctors' opinions? And it doesn't make any sense. So of course you have like a really skilled patient-focused guy with a non-patient focused bureaucratic insurance company guy talking about a case that the doctor's already said, here's the case, here's the presentation, here's why I ordered these tests, you've denied it twice, it's justified, and then usually it gets approved. But why have to go through all of those steps? And think about the amount of people employed to do those things, to deny in the first place, to review the second submission, and now the peer-to-peer. Like how much money was spent to try to deny the care. Where if we would have just approved the care and done it in the first place, it would have been cheaper. Assuming that the doctor's providing, and requesting fair and true services.
Well, I definitely think we have like a massive conflict that we're coming head to head on. We have one conflict is because the system has continued to grow. The system, by I mean the bureaucracy and the regulation, the red tape, the forms, the authorization. It's both at the insurance level, at the hospital level, at the doctor level. As medicine improves, they try and make it safer. And so safer means you now need to do this. You need to get the imaging here. We demand this type of blood test. So as all things naturally get a little more complex, because we know it's really hard to make things simple. So as they get more complex, I think the system unfortunately grows. And then as it grows, it's not like we're bringing on that many more doctors. The amount of med schools that we have hasn't tripled in the last 20 years. So you still kind of have like this regular funnel of creating more doctors for the world, but we have an increased amount of people in the United States. We have more people that we've now said you need healthcare. So that's a part of the obligation of being, a citizen or being employed. It's like, hey, we made it more accessible. So all things have tried to improve accessibility. But like the elephant in the room is perhaps we just don't have enough doctors for everyone. So as the system gets bigger and more bloated, which means that a person needs to see the doctor 3 times to actually make something happen because they have to pass these steps that Medicare mandates. You have to do this, you have to do this, you have to do this.
Right.
So the bureaucracy creates more steps, but yet we have a funnel problem. So it's like we're head to head with like the elephant in the room is there's just not enough people to help the people.
Well, that's one thought, right? So that's been around for a while, right? For the last decade, there's been like there's not going to be enough doctors, not going to be enough therapists to treat the population as it continues to grow, as the baby boomers age and as the population grows, which are kind of 2 big factors. But I would argue, another side to look at is how busy the doctor has to be effective, be effective financially, right? To justify the cost, for a hospital to make money or for a private practice to make money. And don't make no mistake, even though it says nonprofit or whatever, it's there to make money. So if it has to make money, the only people making money are the providers. They're the ones billing for the services, right? Well, if I'm one doctor and I treat one patient, there's a certain amount of money that is needed for that doctor to get paid for that time. But to treat that one patient, if I had to employ 3 or 4 other people to make it possible to have that appointment, so I had to have a scheduling person, I had to have an authorization insurance-based person, I have to have a billing person that does the billing and then collects, and then I have to have maybe something else. Maybe I have to have a scribe or whatever, some other people. Now I've got 4 or 5 people employed to handle one visit. So the math becomes, well, then how many visits do I have to see in a day to make this profitable?
To offset that business cost.
Now I have to pay 5 people to have, to have one doctor. So a lot. You have to see a lot, it turns out, right? And then what does that lead to? Well, that leads to you having less time with the doctor.
Yeah.
Because if he has to see more people in one day, then guess what happens to your appointment time? It goes from 20 minutes to 10 minutes to 5 minutes. Or, you know what, forget it. You're not even going to see the doctor. You're only going to see the PA.
Yeah.
Or the nurse practitioner, which is not to say it's not a good appointment, but it's not the appointment that maybe you'd ideally wanted to see with the decision maker. So it creates this entire, you see the system, you see this happening.
Yes.
So they could say there's not enough doctors, but if the doctors didn't have to see people so quickly and hastily order some things in a much less time frame, that they had able to dive a little deeper onto the person's case, dive a little deeper into the person's subjective, they might be able to diligently look at doing some different tests and kind of be really more strategic about it. Mm-hmm. That's how it used to be. Mm-hmm. Mm-hmm. But now that they have such a little bit of time is one variable. The second variable is that they're required to order certain tests before the actual test they want. Mm-hmm. So if they wanted, it's just in orthopedics, so they wanted to order an MRI, most insurances won't cover that until the x-ray has been ordered first. Mm-hmm. Mm-hmm. And oftentimes they want an x-ray as well. But if they didn't want it for a particular case, like maybe something like a mid-belly muscle strain, maybe an Achilles tendon rupture, they probably would still want the x-ray on that. But nonetheless, if they didn't want the x-ray, they couldn't just jump to the MRI, which means now they have to have multiple sessions, multiple appointments just to get to the thing they wanted. Yeah. So now you have a time issue, and now you have multiple appointment issues to solve one case that probably could have been solved with a little bit more time in the very beginning and the doctor's autonomy to actually be able to make a decision. Mm-hmm. So I think that what happens and people don't understand about the system is I think that the doctor being conscious and aware in the session, trying to dive deep into your case is what we all want. Like if you're going to go see the doc, you want the doc to be conscious and have enough free brain waves to be engaged with you and try to solve the problem, mm-hmm. right? Identify the problem, solve the problem, give you the tools you want. And unfortunately, what's happened with the system is it's really, really made that difficult. Yes. It's still possible, but it's very, very difficult. Yeah. Now the doctor has to see more people because there's not enough money on the table and he has to pay all these other people to do all this bureaucracy work to get the insurance to pay. Yeah. So what that does is it reduces his time in front of the patient. So that's one thing. And then they've also stripped him of all the rights he has to choose what tests he wants and when he wants them. Yeah. He has to now follow a protocol or submit for authorization on everything. So everything that should be fast and effective is now, and that would be called efficient. Mm-hmm. And now he can't do that. Now he has to be the opposite of efficient. Yeah. And he just becomes a line worker on a conveyor belt. Yeah. Of patients coming in and just checking boxes instead of actually diving deep and having an engagement. And if we think, I think that's what's wrong with the healthcare system is the physicians being able to, and not just physicians, but any provider being able to dial in and like engage with their person. And when you look at what I'll say the insurance companies have created it because they're the payers and they've required all of this red tape and bureaucracy to kind of get anything done. Yeah. And that's being supported by Medicare and by the government entities because I think because those people are funding the campaigns. Yeah.
Well, I think, for probably many things in life, in our complex society, I think we're going to have incremental change. And so then my thought would be, well, where are we incrementally growing to? I think more people are using their insurance as in an incremental way, more toward catastrophic insurance. People look at like, I'll just do the high deductible plan because all these variable plans, I'm going to pay out of pocket. I'm going to try and find someone that I connect with, that I trust. And if I break a leg, go to the hospital, well, I'm going to meet my out-of-pocket max. So it doesn't really matter if my deductible is $500 or $5,000. I'm going to meet the whole thing, and I'm going to pay the whole thing with something catastrophic. And if I want to live to 100 and have the best life, I'm going to pursue a little more consumer options. I think physical therapy is growing into more of a consumer option. I'd say probably like maybe a third of my patients maybe need me to walk. And the other 2/3 are much more interested in, hey, Russ, I want to hike Mount Talac. I want to perform at the soccer game. Yep. I want to lift some weight at the gym. So they're more of a performance clientele, not I need you to do my active daily livings. So I think the PT
more like
is
a life or movement coach. Yeah.
I think we are flirting more into the performance concierge box, and I think you're going to have more doctors, more digital platforms, more people in the space that want to be, hey, I can help you live your best life, versus there's going to be plenty of other doctors that like, I'll put you together when you're broken. If you're in the ER or you're in the urgent care, I'm like amazed how much my family uses urgent care. You know, if the kids are sick, go to urgent care. We're actually not scheduling with the doctor. We're going right to urgent care, do a quick swab, find out if it's a virus, give me an antibiotic. We're not going to go to the doctor when we're sick. We're just going to urgent care.
Yep.
So I think like
the transition,
these like models, now you're seeing urgent cares with Google reviews. We got an urgent care in Granite Bay. This doctor is just like amazing. You know, it's got like 1,200 5-star reviews.
Many more than that now, but yes.
Yeah, and it can just incredible, like incredible service. And I'd probably rather like use him for all like sickness things. And then the question would be, what do I use my general healthcare for? I'm not sure. I think I might just use it if I break my leg.
Well, I think we've had some great talks with some executives and some financial people that are investors in the healthcare space and kind of what direction they kind of see some things going. It's really interesting. We know that one of the bigger moves of the last year is like Amazon bought One Medical, which One Medical is basically that type of, it's a work comp group for the most part, but it was an inclusive group where they had PT, OT, general physician, nutritionist, pharmacy, all in one entity under one roof, basically. And since Amazon's purchased them, now you see Amazon having an online pharmacy option where they're starting to serve that. And we've seen many other tech giants. With this talk was really big like 4 or 5 years ago. Walmart was in on it, Apple was in on it, Google was in on it, Amazon was in on it, about how to provide better healthcare for their employees and look at this different option. So some of the assumption is there's going to be more of this, a membership type model where maybe you're a member of Amazon, like a Prime member or a healthcare member of some kind, and you get access to this, something like One Medical, like their healthcare division, and you get a GP that's remote that you could call and say, hey, I'm sick, or you go online most likely and type in that you're sick and you're a member of the group, and they do your stuff, and maybe they order the lab tests. Maybe based on the lab test, they send you some drugs to the pharmacy, and you know, they can either send you to the lab to go get the lab done, or they send you a phlebotomist, get the blood, and within 48 hours, you've got the medicine you need based on the test results. And having that be more of a very affordable membership type option as opposed to an insurance-based option, because that can be provided at a much lower cost. Now, still, like you said, if you break your leg and need surgery, or if you have cancer or some other disease that requires a significantly greater intervention, then that's maybe what the hospital is going to be for, what major medical is going to be for. Yeah, there's kind of this hybrid thinking right now that maybe there'll be growing into that membership space, powered by big tech. Because why? Because they're going to be efficient. They're going to find all the ways that you could submit your healthcare information digitally, have a computer system analyze it, and get that information in front of a licensed provider, a doctor, very, very quickly, and then he makes a decision and makes a recommendation, and it's done.
Well, I think medicine's come a long way. And I think the failure here by the medical community is they have not really updated the public of actually how much they can help people.
Right.
And so, you know, most people don't know that if they had a lot of different tests done, they would highlight how they need to move more, get more sunlight, do these other things. And so most people have no idea that if they actually were best friends with a doctor, they would live a much better life. And that doctor can't really help them because oftentimes they're in a model where it's crammed into like this 5-minute session. So it's like you have amazingly smart people and phenomenal ability of getting great data, and you have this pathway of education, but you don't really have models that allow for people to help people, which is really unfortunate. I do think it's completely bogged down by a heavy, big, bloated system for no reason just to be big. I think that's the problem with bureaucracy. You know, you rarely find a bureaucracy shrinking. It kind of like wants to grow. It has like an energy to grow, a life force in of itself, unless you have a leader with the fierce intent that we're going to reduce it. And I think, you know, that's one thing I think we were really focused on at the beginning is how do we reduce the red tape, reduce the boxes to check for physical therapy. You look at a typical physical therapy practice, and it's like, oh, you need 5 people here, you need 3 people here, you need 4 people here, and then you have the clinician that can finally help someone. Wow, okay. Well, like we really want to help people. How about we just, be focused on PT and see if we can trim all the fat, so to speak.
Yeah.
And I think it's really important, like philosophy. Are you in the philosophy mind of trimming the fat so that you maximize the effect of the person helping the person.
Yeah, we from the beginning when we set out to build Kime, that's how we built it. Was let's put the provider in front of the patient face to face and make that the priority of the organization and what we do. That's the main objective. And then we realized that we certainly have to have a team of people that do an excellent job of filtering the information so that visit is paid and justified and all the things need to go in with that. And so we've called that team our administrative arm, if you will, or a team that handles much of the administration and operations of the backside of things. We've called them the efficiency team from day one. Mm-hmm. We've actually moved away from that language, but that was like for 2 or 3 years, it was the efficiency team.
Key principle.
Because we really didn't want them to, and people we hired, we made sure we hired them not from the healthcare sector. Because we did not want people coming from, oh, this is how I've always done it mindset. Or we did not want people coming from hey, this is how insurance works. Because I really wanted to challenge that model and be like, well, is that just what you've learned how it works over your career? Or is that really the rules?
Yeah.
Are those really the rules or do we just start following them and we just find ourselves kind of following along, which is the truth.
Yeah.
We've flipped it at Kime. We've flipped the ratio where we have 5 clinicians to 1 admin person,
yes.
1 admin team member.
Which means that admin person, and I really misspoke, I didn't mean to say that admin person is literally the fat on the system, but the fat in the human body is actually incredibly essential. You do need like healthy fats or else you don't have an immune system. So to
you can't have people sitting around not working. I mean, that's the thing.
To regurgitate a little bit, it's that person becomes very valuable if that 1 admin person is supporting 5 doers of the physical therapy service that we do, then it's a very potent admin person. If we have 5 admin people helping 5 PTs, it's less potent. They're less valuable. And I think that's a very important principle that we drive in our business is high value at every level. That's like such a phenomenal principle that I think every business should strive for. Let's elevate every role.
Yeah, it's been extremely fun to challenge the system and see the success in doing so. Like the efficiency of that group has been tremendous, and as the company's grown, we've seen the people in that group grow substantially without us having to multiply the group.
Yes.
Which I think it was again our goal from the beginning. If our people can become more educated, more informed, and become more efficient operationally, they can generate more income for themselves, be rewarded for it, and they're generating more income for the company, as opposed to us hiring multiple people to do somewhat, all of them doing simple work. If we can get someone to do more complex work and simplify the system so that we're not getting beat up and having just extra bodies moving paperwork, it's going to be much more effective. So we had some good success there. But anyways, I hope that is interesting on that topic. I think it'll be interesting to see what comes. But it's disappointing to hear of a person who's a veteran and gone through the process and then now struggling with it. I appreciate the challenge, and that was kind of my thoughts too. It's like, man, this guy could go concierge, but now he's going to spend another couple grand just to go to the concierge person. And I was thinking, this guy needs all he needs is like a online doc, like an online system where he's a membership to, and he gets access to a doctor, has a 5-minute conversation, be a 10-minute conversation. Well, the guy orders some tests and he moves on.
Well, the ultimate myth is that whatever dollar you put in your health care, somehow that pays for everything regarding health. Talk about a crock of shit.
Oh, yeah.
No one ever said that as a rule. No one ever said this is how the game is played. But people have that assumption. Why only want to do things that are covered? Well, what if I said your life is now limited because you're only going to spend your health care insurance dollars? You will now live 15 years less than I do. And what if I told you that? Then you might say, well, that's not fair. Well, yeah, but it's a game. Society has built this game. Of course it's not a fair game. Of course it's going to break under load. Of course when it gets bloated and fat, it needs to change. That's how every game in the world in the dawn of civilization has to constantly evolve and change to meet the needs. Or once the system gets too bloated, you have to, again, change some rules. Yeah. But it's an inappropriate thought to say, well, I really only want to do the things that are covered. In fact, any loved one that says, they say this is what's going on. Say, well, I recommend you go this pathway. I'm not sure if my insurance covers that. And I tell them, stop thinking like that. What a short-sighted thought that is.
Yes, and I think to defend the insurance companies and take that side, is the one thing that they agreed to in the very beginning that's been changed on them, which I understand why they'd be frustrated and why their model doesn't work anymore, is they were there for major medical. They were there for like, hey, if you're going to die or emergency medicine, that's the goal of insurance, not to cover all of the day-to-day stuff.
Yeah.
And, as the day-to-day things have mounted up and now there's little things that they're paying for and paying for all these doctor visits and paying for all these drugs for and stuff, it's like, I could see how there's no money left for them to do it. So they have to find other ways to continue to stay profitable.
I mean, look at that logic for car insurance. If you have car insurance, do you use it to change your oil?
Right.
Change your tires? Get wiper fluid for your windshield wipers? If you do all those things, the car can go 300,000 miles. If you don't do those things, it lasts 80,000 miles. Your insurance helps you when you get in an accident.
Yep.
So we have this like really incorrect idea. Completely incorrect.
Maintenance is different than insurance.
And frankly, maintenance for my body is a shit ton. My body requires a lot. I have to get 8 hours of freaking sleep every night. I have to drink these protein drinks. Why do I have to? It's because I try and hit people in the head. And it's really hard to fight in martial arts when you're living off of McDonald's. It's quite impossible. So I have a high demand body. That was my choice. So once again, if it comes down to healthcare, whatever your work pays for, if you just stick to that, that is a choice. Or you could spend some extra dollars and find great people. That's also a choice. But this idea that it all should live within the health insurance model, like, well, whoever said that?
Yeah,
like a Ferrari versus a Taurus. Like, really? Those are different vehicles. Don't you think it's like a little bit different to manage them?
Yeah.
Not to say I'm a Ferrari. Maybe I'm a truck, a Ram Rebel.
I don't think you're a Ferrari. Well, I don't know. You're very, very focusedly skilled. But you could do multiple things, but only one at a time.
yes.
It's very, very important that you're focused like a sniper. You're more like a sniper, which I'm not sure.
Yeah, but
because like some days you could be like, no, I'd say you're more of a high performance vehicle. You have to make sure the vehicle's on the right track.
If we change tires, we're smoked.
Well, if we change tracks, that's where things get really wild.
Yeah.
That's where the brain goes sideways.
I actually reference that to all my pro fighters. I tell them like, hey, you're in Humvee trying to be a Ferrari. Not going to happen. That's Max and Fluff. I tell them that they're Humvees.
Yeah, you can handle anything, which makes you more like a truck, but you really are excel when you're on a track.
I need a nice track.
Vehicle. Yeah,
nice track
for sure. Yeah. Which I think is a good way to be. I mean, that's high performance, right? You don't want to just be the beater that just survives.
It is a choice. I've asked my parents who are in their late 70s, well, how long you want to live for? I told this my Nina. My Nina had a really bad back. She's 75, had a severely bad back. And I told her to do some things, and she's like, well, it's been hard, Russ. Well, how long do you want to live, Nina? Isn't it like, it's like, comeback. She's like, what the F? Like, really?
You're not allowed to.
This is a PT session. I thought you were going to help me with my back. I'm like, yeah, I'm asking how long do you want to live?
I'm trying to determine the motivation factor.
But she got better. She did her work. I'm proud of her. She was doing exercises. So, but it's like, what's your identity?
The funny is that question comes back to like something we face in our field. Like forever, everybody wants to talk about like PT and like you give your patient exercises, and we call it a home exercise program. Is like the language for it. Did you give them a home exercise program? And there's been all of this data for like 30 years that's like just ripped home exercise programs. Yeah. Like people don't do them.
Yeah,
they don't like them. The compliance is down.
Yeah.
All of the research in this space is like the patients suck.
Yeah,
right?
Yeah.
I have never found this to be true.
I know. Like patients are amazing.
I've never found this data to be true. Yeah. But if I was in a system where all I did was like ask your name and what hurts, and he said my back, I said okay, well here's a sheet.
Yeah.
Then yes, I think that the compliance would be quite low.
Quite poor. Yeah, I think it's directly correlated to education. But if I get to spend
some time with you and understand who you are and how long you want to live, perhaps, and then we speak to like how your movement dysfunction is not going to allow that to happen, the compliance goes really high.
Yes, yeah. That's the problem with that type of research. Is that research? It pretends that it pretends a lot of things. But it pretends like there's a good value exchange. In the therapy model, compliance is poor. Like, what if it's completely poor because the therapy is poor?
Yeah.
What about that?
Which is what it proved, as far as I'm concerned.
Yeah, yeah. And then I'm sure it really comes down to like, it probably wasn't the therapist was poor. It's probably they were given too short a time and they had 30 evals that week and they forgot who the person was. So now it actually comes down to a broken model. Exactly. So here we go once again.
Right back to where we were. To the start of the conversation. Exactly. It's directly tied to, the model determines the quality, unfortunately, which is true with any business. Any system.
Yeah.
People have to understand that you could have the greatest provider in the world in front of you, but if they're not allowed to think or give you the time of day to dive into the case, then they cannot be great. Mm-hmm. They will eventually succumb and become average or below average because of the system or the model they're in. Mm-hmm. And that's what the message is. And that's what's so hard right now, is that the people controlling the model is essentially the government, because it's Medicare. Every insurance company bases what they do off of Medicare. Mm-hmm. So, it's gone the route of, we're going to support all of this kind of non-efficient work, all of this high cost stuff, all of this denial and approval and authorization modeling. And that modeling is just basically put more space between the physician and the patient.
I mean, the free market thinker in me would hope that if you have a competitor in the space that challenged the other people that weren't doing great work, or the other entities not doing great work, you'd get change. But, I really haven't seen too many new insurance companies pop up in the last 20 years. So it's kind of hard to find.
There does be a shortage of that, yeah.
So without a competitor, do we actually have a market, or we actually just have a good old subsidized system?
Back to the thing, that I think that the competitor is going to be tech.
Yes. Yeah. They're big enough, strong enough, and they got data.
And they have employees.
Yeah.
Their line item cost of how much they're paying for insurance is astronomical.
Yeah.
It's probably their second highest cost besides payroll.
Now, you saw this with athlete performance with Exos, right? Didn't they? Yeah. They got into the Intel centers?
So they did. So they became a health and wellness company. So they were working at Google and Intel, Sheraton Hotels, Walgreens, many companies working with their employees. Mm-hmm. And the goal was to help improve employee health. And employees participated in the program. The insurance companies incentivized that participation and actually knew that it led to lower costs of healthcare, so it would decrease the premiums. Mm-hmm. So the users, the actual people who participated in the training, would actually get a discount on their healthcare, like $100 less a month or something like that.
Yeah.
So it started to become valuable for them to participate. So they were encouraged, incentivized to participate, and that was a good. That happens. There's a lot of people doing that.
Yeah, it's still going. Right?
Oh, for sure. Yeah, absolutely. Yeah, Google is still a huge factor in this. Intel's probably doing a lot less of it since they put the whole workforce from home, and they haven't really called them back to the same degree the other folks have. Yeah. But Intel's in a different situation. They've also, I'm speculating on this number, but I know for sure that over 5 times in the last 7 years they've cut their employment by over 10%.
Yeah.
So I think they're probably dealing with less than 60 or 70% of the population they once had.
Yeah.
But they're in the process of building new fabs in Ohio, and once those get done, they'll probably have a resurgence. But they're definitely cutting their team.
Well, I will say that being a PT in the community, it is extremely enjoyable as a physical therapist to see the young baseball athlete, to see the college soccer athlete, to see the mom, to see the knee replacement, to see the firefighter back pain. I love the diversity. So, I'm sometimes, if you overthink efficiency, put a PT in every work spot, and then dealing with all like office workers. And if my day was filled with 12 office workers, that's all I did was just work from the office, and they all have the same type of back pain because they're sitting in a chair all day. It'd get a little old.
Yeah, it has difficulty because then once again you kind of succumb to the system that's there, and it's good I think it's really good for the employee actually to leave the work environment and go get stimulated by an external source. Like, because if everything's internal, at some point you kind of run out of, you either run out of bandwidth, you run out of passion. You kind of have to. There's the thing called third space, right? So this is a real psychological phenomenon. You have to have a third space. So you have your home, your work typically, and then there's a third space, which is usually kind of like, think of it like your social network. Mm-hmm. So this is varying for different people. Some people use the gym, some people have a yoga studio, some people go to the cigar lounge, some people go to the bar. Is their third space. And it's the place they like to hang out or like to be away from work and home. So in America, it's a real practice. And you might find that you're searching for a third space and not knowing it, but it's a very real thing. So by having work and fitness and health all in the same space, I think mentally that doesn't jive very well with the way the brain works, or the way the culture of the population is. So I don't know. It works okay, but
that's a great insight. I find like a lot of my patients that have done really well, they see, coming to KIME at a gym as a third space, whether it's for 6 months or 2 years or, a short stint. But they almost excited to come back. Hey, I'm excited to come see you again. I got a new thing. It's kind of weird to see a patient when they're excited to come back because they got a new thing.
Yeah.
Like, oh, you're excited about a new injury? But they like that, they like the atmosphere, the vibe of let's get healthy.
Yeah, it's definitely a temporary space to be in, and there's an energy around that for sure. And I think that they probably see you as a coach and how to use their third space, which might be like they like to go hiking, or they like to go skiing, or they like to be active or do something outside or play a sport, right? So both of those things I think are true. Now, when someone doesn't have one, like you tore your ACL and now all of a sudden you're not on the soccer team anymore, you're not playing football, and that your locker room's taken from you, and there's no practice to be had, then we definitely become that third space for at least a 9 to 12 month period. So
I think it's one of the most things that I'm most proud of, and one of my proud things about how we structure our company is doing like the pro package. When a young athlete gets injured, all of a sudden they're ripped from their activity every day. They're like, hey, come after school. Yeah, let's go for an hour and a half. Let's get your body right. You do that for 9 months because you're not doing anything else. You got 2 hours of homework, but like normally you're doing practice for an hour and a half for after school, and you take that away. So we become their new practice. I think it's so awesome on the youth development, on the improvement of their brain psychology and the sense of belonging and getting some work done. I love it. Yeah, it's fantastic. It's needed because they've definitely kind of gotten lost, and then they need the coaching on exactly what to get back to. And then once they get a rhythm going, they really can execute and take pride and develop the confidence in the process. Yeah, it's good. So on changing topics a bit, we had a great week last week, and really not launched our fellowship program, but more finalized our first pass through the fellowship program, which was super fun. So. Congrats to Evan Hoggar and our team, who's been a PT with us for several years. And we put him through the gauntlet of our fellowship testing process, which is really a clinical assessment as to, do you have the right thought process? Do you have the right approach? Do you have the clarity of thinking that you can engage with a client and a patient at all levels? Can you engage with them, with their family, with their coach, with the emotions, with the psychology of the injury and what's going on? Can you engage with them to diagnose the injury properly and then put them on an appropriate plan that's robust? Not just, hey, this would be cool if you did it, but this is the movements that you're going to have to get back to doing to play whatever sport it is, and then we're going to build these pieces, A to Z, to get you to do it. And then in the meantime, you're going to need to have this kind of sleep, nutrition, and other supportive things on board to get there. So we've been wanting to do this for quite a while, and we've been building up this version of a fellowship for quite a while. And, I think that there's fellowships that exist, and what we wanted to answer in this particular program, this particular fellowship, is that it's a truly clinical application, and that you have to demonstrate knowledge and expertise in actually delivering it. Everything from your manual techniques to your exercise progressions, to your communications with the patient, to understanding the billing concepts and the business around it, so that you have a full understanding of what it is you're doing. And that to us is what it meant to be a KIME fellow. Mm-hmm. Yeah, and during the 3 hours, he presented 3 cases and then a team report, which was a team testing. They tested the Sac City baseball team. And so if each case took about 30 to 45 minutes. And it was great is kind of asking him, why'd you do that? How did you do that? Show me. How did you progress it? How did you program it? What did they do? How did they respond? And it was a constant open-ended question of hows and whys and details and specifics that allowed him to expand on a thought process that was very much not like, let's try this, but very much like, I knew that this needed to happen. These were the dysfunctions. This is our pathway. I was challenged here. We progressed here. We had a speed bump here. We worked on this. 6 weeks later, we were able to do this. Another 6 weeks later, we were able to do this. According to these timelines, it makes sense. These were drawn out cases that allowed him to expand on every detail. But it was really great to hear him do most of the talking. And you and I just ask questions. Why? How? Tell me more. What do you mean?
Yeah. What would you have done if this had been the result? How would you have changed your approach and the strategy? And to really see a person own the information and be fully comfortable in their own skin as well as comfortable with what that would look like with the client in front of them. Because this is what we see every day. I challenge new PT grads with this all the time, as they always come in and they're like, man, I'm so glad to be done with my last test. I'm like, you haven't taken a test yet. You're about to get tested every hour for the rest of your life, for as long as your career goes. And let me tell you, the person on the other end giving the test doesn't want you to get anything below 100%. 72% is no longer passing. Much less 80 or 90%. Like, it has to be right. Yeah. And I think that's a reality that we have to face as a provider, as a clinician, is that the patient deserves the best possible information out there. That's what we built our brand on, built our business on, and built our structure around, is like, how can we deliver that and make sure that the therapists are in place? This is just another step to do so. In the fellowship world, there's several out there in PT, but they're pretty specific. So you'll see the fellowships on there'll be sports medicine fellowships, mostly like on-field training. There'll be sports medicine fellowships on, the knee or the shoulder, or like very specific type of approaches. And we wanted to have something that was equally as specific, but demonstrated the understanding of the whole picture, of the big picture. So yes, you have to understand the knee inside and out, and what the potential diagnoses are, what the potential surgical options are, what the techniques are, who the best doctors in the world are, who the best doctors locally are to help address these issues, and who this person might see, is all part of the process to be a great clinician, to be a resource for the patient in front of you at a high level. Mm-hmm. So we wanted to build that in this fellowship program, and then we wanted to obviously test it in a real way and not have it be a didactic exam or something based on research or literature, although it is, you have to know the research and literature to actually integrate it and then present it in a functional way.
Yeah, it was really cool. It was extremely awesome to hear him expand like he did. I know, and I have faith that everyone in our company is going to be able to do the same. Expand on a case with command. Yeah, it was really cool.
Yeah, it's what the education process we've been building is designed to do, is to develop clinicians to a point where they can do this. And then now to recognize that accomplishment with this fellowship reward and incentive is super cool.
It was really fun to hear him be a little creative in certain spots, but also really steadfast and strong in foundational systems in others. And I think that dichotomy is really, really difficult for a PT to know. We all want to be a little artistic. We want to be a little creative. We want to think of something new because it's kind of spicy and has its variety, and it kind of fills a little bit of that dopamine, aspect to what we do. Doing like a boring drill, like sometimes is not that exciting. Now they work insanely well, like pushing a sled, super boring. You can coach it up or you can not coach it up. I think a lot of people don't coach it up, so I think you should coach it. But sled walks, I just had a athlete doing them the other day. They're very boring. I do this for the next 7 minutes. I'm gonna be bored watching you, but I know it's really important. So when you're steadfast in foundational systems that allow the body to adapt in wonderful ways of hypertrophy and mitochondrial density and whatnot, that's really important to let that take place so that the seasoned PTs are patient with that progress, are patient with that programming. And then be creative where you can be creative. And it might be really important to be creative. And I think that's where sports and some nuanced high performance people out there, they have particular demands. I got like a professional pickleballer on my list right now. I'm kind of excited. I've had a lot of pickleball athletes, but not like a pro. Right. So he's really motivated. It's really cool. I'm like, all right, I'm getting the nuances of pickleball, but it could be the nuances of anything. And I think that's where the motor control coordination exercises that allow people to be really specific with their body, I think are fun. And I think we can expand in that area.
Yeah, love it. I learned something from a mentor, and then I was at a presentation with Mark Verstegen one time where Mark went through this. He's like, as a trainer, as a clinician, you have to have a library in your head of like what the potential movements are, the potential exercises are that you might need for a certain sport, and you should be able to just have them categorized. Like, hey, I need glute activation. Okay, I've got a single leg bridge option. I've got a side sit hip lift. I've got a frog. I've got a tactical frog. I've got a variety of things I could use to hit this. I could do some sort of single leg RDL or a T hip rotation. So I might have 6 to 8 exercises in my library that would easily activate glute. And then the question is, okay, who's the person in front of me and what would be the best tool for them? How could they use it at home? How could they use it in the gym? What would they be doing? So having the creativity comes down to understanding how to leverage the library. The other mentor taught me the significance of building a library that's somewhat sound and consistent. So when I first came out, and as a the clinician, you think you're going to change the world and everything, which is great. I've nothing against that. Please go do it. But one thing that sometimes people try to do is to recreate the wheel, right? And then every time they feel like they have to be creative and like, well, I'll make it totally custom for the patient. I know we were taught this in school. It's like, no protocols, don't follow the protocols. You need to create your own thought process and your own mindset and learn how to diagnose and then progress properly. And I was like, I listened to that and I was like, okay. And then I got out into the field, and a couple years in, I got with this guy and we started looking at things, and it was really, really helpful. I learned the value of being very consistent with my treatments. Mm-hmm. So let's say I had a rotator cuff repair or had a ACL or had a back pain or you name it, ankle sprain, being very consistent with my treatment progression, even though there were some variables within the person's presentation, to still be like, well, these are my rocks. Like, I need to build mobility. I need to build strength. And these are my 10 exercises I use in this condition to build them. Mm-hmm. And what that allowed me to do was really develop a skill set and understanding of when someone's moving along the progression effectively and they're following the steps, how fast it goes. Mm-hmm, mm-hmm. So if I had 10 people with an ankle sprain and they went through the same 10 exercise progression, I developed a very clear understanding of like, hey, this is good. Mm-hmm. This seems to be good, right? At least it's consistent, right? Mm-hmm. And then if I had someone come in with an ankle sprain, number 11 on the list came in, and they sprained their ankle, and I put them on the same system that I'd been using that had success 10 for 10 times, and they weren't successful. Mm-hmm. They were starting to fail. Then I knew I had a problem. Mm-hmm. Like, okay, well, is the person non-compliant? Mm-hmm. Did I misdiagnose and put them on the wrong path in the first place? Mm-hmm. Because I know that path works. Mm-hmm. So I can't sit here and question my exercises, or I can't sit here and question my thought process. I know this works for most people. Why is it not working for this person? Mm-hmm. And then I can be very specific. Say, okay, maybe I need to get off the freeway and the clear path, or maybe I need to do a little more of a side path, make a few modifications, and then get creative there.
Yes,
that's where the creativity should live. And then once I got the person over a few hurdles, then get them back onto the main path and get back onto what we know is consistently effective.
Yeah,
like who doesn't want that? Like everyone says, well, I want a custom program for me. No, you don't. You want a program that you know works.
Yes.
And you want that program then customized for you.
Yes.
So that it works in your life.
Yep. I think in the space we've used the word recipe. Yeah. And we have a lot of recipes, and recipes that are very, very good. And I think the best recipes have these custom angles, little offshoots. Sometimes it's an offshoot that redirects them. Sometimes they had a little flare up and we have to kind of take a county road back to the main highway, so to speak. So I think we can drop different metaphors here, but to learn great recipes and then learn how to customize those recipes makes entire sense. It allows you to remember it. It allows you to teach it. You get good at a skilled progression, and then you get creative when it demands it. When you get creative a little too early and you didn't really learn the recipe really well, I think you find a lot of failure. You didn't progress correctly. You didn't build tolerance. You didn't build load because it was just either too variable or too much of an offshoot, or frankly, what I see, too much, weird mobility and coordination and not enough like guts, like let's just challenge the system. And rather than like playing a piano piece, so you really kind of have to have some bandwidth of I know this system well, and then I know it so well that I can customize and come right back to it because I've got my staples. And that's, I think, a pretty sound way of learning. I mean, I think a chef would learn the same way.
I would argue that they should. I think that this is one thing that's big in our field is that there's this challenge. Like don't just fall in line and just do what everyone else does. And I agree. I mean, I have no problem with that. So certainly pick the right person to fall in line with and learn from, but then establish consistent approach strategies, consistent ways to get glute activation. Let's find consistent ways to get running mechanics dialed in. Let's get consistent ways to do return to sport after an ACL injury to basketball. And then let's have a specific system that you utilize that is kind of 80% already paved, right?
Yeah.
And built in and proven and tested. And as you do that over time, you'll have this phenomenal reliability. Then when you get a patient, it's your responsibility to assess the patient, determine where it is they fall into that system. And is there things that need to be a hybrid version, right? You need to customize.
Yeah.
But I think that this is really important where don't be custom from the very beginning. Have a system in place and then customize off of the system. Yeah. You mentioned recipe, which I think is a great word. So my understanding of recipe, now a little something about me,
it works well for you, doesn't it?
Yeah, I know nothing about cooking at all. So this statement is completely hypothetical.
You could have a recipe for building a house, though.
I do have a cooking story from this morning. But my understanding, if I'm not mistaken, is that a recipe would, there is, again, a consistent approach, but every time there's small differences, like the temperature of the environment, the thickness of maybe the air and other factors.
Was it cast iron?
Yeah, the pan. Good one.
Which butter?
Yeah. Yeah, so you've already extended far beyond my skill set.
Yeah.
Clearly. But so that's the same. It's the same concept. Is that you have this consistency of approach, but yet you have to modify it slightly so that you get to the end goal is always slightly custom because the person you're dealing with is custom and the foods that you're dealing with is custom in a custom environment with a unique pan and maybe a different oven. Who knows? Mm-hmm. But it's interesting. So this morning I found myself my son Luke, who has a very limited palate at this time in his life. He's 14. So he doesn't like to eat eggs, and we've taken out a decent amount of dairy because we found that it creates more acne for him. Yeah. So, which is great. It solved that problem.
Yeah.
But now he's like starving.
Yeah. I need calories.
Yeah. He's like, how? He's already this morning. He goes, I don't know what to eat for breakfast. He's like peanut butter and toast, And I'm like, well, you could have yogurt, you could have berries, you could have toast. I said, he loves potatoes, right? Yeah. I said, you could have hash browns, you could have potatoes. I was like, you want to try that? He goes, I said, you got to learn to eat eggs though, bro. Like if you want to grow and you want to fuel the system, you've got to learn to eat eggs. He's like, I can't stand the smell. I said, we'll figure it out. But I don't have time for this right now. So let's do hash browns. So I went and got them and I made them.
Yeah.
I mean, as I was waiting, I was just becoming more and more irate with every minute that went by. I was like, this is not the right way to start my day. Cooking over the stove. And this
it's big.
He ate them though, so at the end of the day, I did good enough too.
Cooking on a Monday morning, man, it's like a Saturday morning activity.
For me, yeah.
Cooking hash browns, like hash browns on a Monday.
It's a never activity for me, Russ, but I can do it. Yeah. But it's certainly not a skill set.
I asked my girls, you want a hard-boiled egg, you want an over-easy egg, or you want a scrambled egg? All three are eggs.
Yeah. Yes, indeed.
So they all taste quite different.
They do.
So it's like, if one tastes up, it looks like you're trying number two because you haven't tried number two yet. Yeah. And then I don't even care what they put on it at this point. It's like...
it doesn't matter at that point. I'm a scrambled egg guy myself, but Leah's not so much. And then, we don't know about Luke. But don't you think like the over-easy would be like the least smell and like the most...
Yeah, well, I crack it. So when Harper was kind of a little sensitive to it, I'd crack it and kind of get a little flatter, and then she was great. It was like over medium with the flat
it was broken. Yolk. Yeah.
Try
I like it. Yeah, we're gonna get some stuff done here. I think we have to go like a breakfast burrito round. Maybe we can do the eggs with the hash browns.
For sure. Yeah.
How could you go wrong?
And I have been doing a little more coconut oil, so I think coconut oil works really well.
I think I'll just slap him and then give him some. Tell him to get over it quickly. What else we got? Good?
We're good.
Good.
Let's go test some firefighters.
Yeah. So this is great. We have a new relationship definitely evolving with the fire community, with our nonprofit. We're super excited about being able to work with the firefighter group. And today's we got to do testing with them this afternoon and get this rolling. But super big honor to serve those that have served us and continue to do everything they can for us. And I think there's a huge problem that we identify that that they have injuries that aren't addressed well. In general, in the entire firefighting community, we have just like we have in sports, where we have people tearing their ACLs. We've known for years, 20, 30 years, how to prevent these things, but it's not being done. The argument isn't identification or knowing what to do. It's the argument is doing it. So what we're designed to do with the nonprofit is actually go into these entities and actually help them develop better practices, help them develop habits that could reduce these further risks of mechanical musculoskeletal failures and such. So we're excited to get that off the ground.
Very good. Yep.
Cool. Thank you guys for listening to KIMEcast. Looking forward to the next one. We'll talk to you guys soon.